welcome back to Midnight Med. This video is on seizures. So what is a seizure? A seizure is an abnormal discharge of synchronous electrical activity in the brain. And epilepsy is defined as a syndrome of recurrent, unprovoked seizures. The key types of seizures to be aware of are generalized seizures, which are ones where the electrical activity goes over the entire brain. And these can be further classified into tonic-clonic, myoclonic, atonic, and absence. And there are also partial or focal seizures, where the abnormal electrical activity is confined to one part of the brain. These can be defined as either simple or complex. They can also start focally and become more generalized over time. The key precipitants of seizures include drugs, electrolyte derangements, hypoglycemia, trauma, infection, structural issues, and there are some seizures that are paroxysmal. Some of the key epileptic syndromes to be aware of include childhood absence epilepsy, juvenile myoclonic epilepsy, and Lennox-Gastaut syndrome. The main differential to be aware of is syncope. The difference between seizures and syncope is that seizures generally take a lot longer to regain consciousness, and this is called the postictal period. Classically, it was thought that tongue biting and incontinence were key features of seizures that were not seen in syncope, but these can actually occur in both, and so this is not a reliable discriminating sign. The diagnostic approach to seizures relies very much on the history, and the collateral history is very important as well. It's important to note whether they have had a past history of seizures too, and if so, what type of seizure they had in the past. The first question is, were there any motor signs? So tonic-clonic would be where the patient goes stiff and then goes into jerking or twitching movements. A myoclonic seizure would be a seizure with just the twitching movements. An atonic seizure is where the body loses all muscle tone and the patient may even collapse if the atonic seizure is generalized. An absent seizure is where there is a momentary freezing in behavior and or attention. The next question to ask is whether the signs were localized or generalized. If the abnormal movements were localized to one side of the body, then we would say that those are focal tonic, clonic, or atonic seizures. There is also the phenomenon called the Jacksonian march, which is the migration of the abnormal movements from one side of the body to the other. If there are abnormal psychological or sensory experiences, these are usually focal and can be from the temporal lobe, the parietal lobe, or the occipital lobe. And a focal seizure with loss of awareness is known as a complex seizure. If the signs are seen over the whole body, then we say that this seizure is generalized. However, it's worth noting that these seizures can start in a focal area and then progress to generalized seizures over time. Next, we want to know whether there was a postictal period or not. If so, how long was this postictal period for? Examination is very helpful, particularly the neurological examination and cognitive status examination. If these can be done during the seizure, then they would provide a lot of information, but obviously this is not practical in most cases. So often we might need to do these after. They can be especially informative if the cause of the seizure is something that's structural or drug-related or potentially related to infection. And we might be able to identify the presence of meningitis, encephalitis, or even a space-occupying lesion like a tumor on a neurological and cognitive status exam. The key investigations to do would be to rule out some of these causes. So we do EUCs to rule out electrolyte derangements. We do a blood glucose level to rule out something like hypoglycemia. We do an infective screen and potentially a lumbar puncture if we're suspecting something like meningitis. And we could do an MRI if we are suspecting something like a tumor or a space-occupying lesion. If there's no obvious cause on these, then we might do an EEG, an electroencephalogram, and these can also be useful. Again, if we can do that during a seizure, then that would help us diagnose what type of seizure is occurring. However, this may not be practical. We may need to follow them up with an EEG over time. The principles to seizure management include basically just treating the cause. So if there is a cause, treat that cause. So whether that be an electrolyte derangement, whether that be a tumor, an infection, or so on. If the cause seems to be organic, then we would use anti-epileptic medication. And I encourage you to have a look at the video that we made recently on anti-epileptic drugs for some information on the indications, contraindications, and the mechanisms of action of some of these medications. So for a generalized tonic-clonic seizure, valproate is the first line, and lamotrigine and levetiracetam are second line. For an absence seizure, valproate or ethosuximide are first line, with clonazepam and lamotrigine second line. For myoclonic seizures, valproate again is first line with clonazepam and levetiracetam second line. And for a focal seizure, carbamazepine is first line with lamotrigine and levetiracetam second line. That many medications may actually be used second line. I've just listed these ones for a bit of consistency so you don't have to remember too many. And it's worth noting that some refractory syndromes, such as Lennox-Gastaut syndrome, may benefit from dietary changes such as a ketogenic diet. So that's it. Thanks for watching. Don't forget to like, subscribe, follow us on Instagram for more, and we'll see you in the next video.